this is a messaging training, and it's really focused on PNHP's campaign against Medicare Advantage. And I think one of the most important points to make for you all is that we are not the only ones in this fight. And we are working with a coalition of lots of other organizations across the country. We have a special guest tonight, Carmen Rhodes from Be a Hero. She is a leader with that organization, and we've been working very closely with them on this particular campaign. So in addition to hearing from some of PNHP's leaders around this, we're also going to be hearing from...
Thank you, Laurie.
And I think that that's just going to be a testament to help you understand that this is a coalition that's working on this. And so, you know, it's great to see all the names trickling in. I'm going to turn it over now to Dixon. Dixon, give us a sense of what the run of the show is going to be, and we'll kind of go from there. Dixon?
All right, will do. Thank you to Dr. Verhoof for that introduction. Yes, and as Phil mentioned, we're going to be talking about messaging on what can be a complex but is obviously a super important topic, and that is the Medicare Advantage program and the dangers that it represents. So we're going to have a number of speakers here tonight. We're going to start off with Dr. Ed Weisbart, who I will kick this off to in just a moment. He's going to talk about some high-level messaging for how we talk about Medicare Advantage in virtually every context. Then we're going to go on to how we address this program with specific audiences. So this can vary depending on who you're talking to, and we're going to give you some messaging suggestions based on whether you're talking to physicians or people who are working within the healthcare field, whether you're talking to the general public, which I know is very broad. These categories are broad by necessity, or whether you're talking to health justice activists, people who are on board for single payer, academics, or legislators. So we'll get into those categories, and then as Dr. Verhoof mentioned, we will hear a real world example of how these messages have been put into practice from Carmen, and we'll wrap up with some action steps that people can take. So with that, I'm going to pass things along to Dr. Weisbart.
Hey, thanks, Dixon. So this is a pretty exciting session to me, because most of what we'll be talking about for the next hour is stuff that is pretty cutting edge new. It's things that I'll tell you I didn't know just a few months ago, and it's things that I'm still trying to adopt. So there's a lot here that really is changing how I think about things and how I communicate. And I hope you find it as useful as I do. So I think you can see my slides. Yeah. So we're talking about how to talk about Medicare for All. And one of the first messages here is that we're not talking about tonight about how to win an argument, how to conduct a debate, how to respond to big, fights. We're talking about how to more encourage people to join us in this campaign. So to be clear, we're still really talking about what PNHP has been talking about for 35 years, which is how do we get to single payer Medicare for all? And to that, the context of what we're doing tonight, of course, is that we're still feverishly fighting to pass the Medicare for all legislation, which, as you know, there's an active bill in the House and an active bill in the Senate. And you probably know that PNHP chapters around the country have been very aggressive and helpful in working with our allies to get co-sponsors to these bills. So everything you're going to hear tonight is not meant in any way to change the fact that the end game we're trying to get to is pass this legislation. So two other legs along the road are, as we've been saying for a long time, improving traditional Medicare, and that means eliminating all of the copays and deductibles and adding in the benefits that we all know are missing. And then lastly, more on the topic tonight, focusing on ending the corporate takeover of Medicare. And we're focusing on Medicare Advantage, although there are many areas in which healthcare is, of course, being taken over by corporate profiteers. But tonight, and most of our campaign is focused specifically on Medicare Advantage for all the reasons that we've been talking about in other settings. We're talking about messaging tools tonight, but there are a wealth of other tools on the kitchen table campaign on the PNHP website And one of the things to bear in mind is that although we're talking so much about Medicare Advantage lately and for the near future, the conditions that will enable us to win this fight for Medicare Advantage are the very same conditions that will help us win the fight for Medicare for All. So these are overlapping milestones rather than different campaigns. And you may have noticed that I called it Medicare Advantage. Why did I pick those words? Because it doesn't, there isn't one set of answers to what words to use. So, for example, do we call it traditional Medicare? I tend to call it that. I tend to avoid the phrase original Medicare. I have no focus group data to tell you that one is better than the other, but my personal sense is that traditional is something that people like things with tradition, but original sort of implies that there's a new and better alternative of Medicare Advantage. And one of the only real data point I have to prove that to you is that the Medicare handbook specifically has switched over to calling it original Medicare and no longer calls it at all traditional Medicare. And we know that the handbook is in many ways biased towards the profiteers. So that's maybe a suggestion. So do we call it original Medicare? Do we call it true Medicare? Some people like that, still got the T initial. Do we call it real Medicare? Or do we call it the technical words Medicare Parts A and B? There is no single right answer to that. Likewise, do we call it Medicare Advantage, or do we call it so-called Medicare so-called Advantage? Do we call it disadvantage? Do we call it privatized? Do we call it fake? All these answers are right. None of these answers are perfect. And I don't have a right answer to this, but what I'll tell you is that this is not the right discussion. This is the discussion that we've had for years and years. Is it this? Is it that? Which word do we use? And there isn't. We're not going to get to Medicare for All by picking the right one of these choices. So tonight's to try to get us a little bit further. You heard a few words about Be a Hero, and wow, those folks are heroes. And you'll hear a little bit more about them in a moment. Be a Hero has been working with this group called ASO Communications, which is essentially Anat Shenker-Osario organization. And they have been developing, Anat Shenker-Osario, her team has been developing a whole bunch of stuff that's focused, that's the basis of what we're talking about tonight. But it's important to point out that this is still very preliminary. This is in the early phases, as is our entire campaign. And indeed, this is sort of an analysis rather than a focus group tested set of data, which perhaps with luck we'll get to at some point in the not too distant future. But so understand that what we're saying, I think, makes a great deal of sense and is a few little leaps of faith. So the first thing that we're learning is that we should lead our discussions with the shared values rather than the problems that we've tended to focus on. One thing Anat Shenker-Osario likes to say is that Americans, this is a direct quote of hers, Americans got 99 problems and they don't want yours. They're not trying to collect number 100 to complete the set. So they're not looking, nobody's looking for that. On the other hand, if we had these discussions on the basis of values, we win. We win when we talk about things based on values. She also tells us that when we're trying to talk about healthcare issues, framing them in the sense of family, community, fairness, freedom, those are the frames that really seem to resonate the most when she's studied this in other contexts. So in essence, the language that we've tended to use about things like this one example I gave you, the gap between rich and poor, is it has, statements like you see posted here. Rather than do that, she says, and I think this is right, open with sort of common values and shared vision. For example, this sentence, no matter our differences, most of us want pretty similar things. Try to build the bridge, open with shared values rather than problems. These will become increasingly different from how we usually talk as we go through this little sort of bit here. Don't shield culprits from view. And we do this a bit too much today. So it's important to describe who exactly is doing what exactly to whom. If you don't have a clearly specified villain, then it's hard to know where to target your advocacy works. So where possible in our movement, we should be targeting as much as possible specific health insurance corporations. Not companies. Companies are friendly, warm, and fuzzy. Corporations, focus on that. Target specific health insurance corporations rather than the privatization broad concepts of the program writ large. So an example of that would be, rather than saying things like our system is just hopelessly fragmented and wasteful, which we say, I've said that a million times, you know, our system is fragmented and wasteful. No, there's no culprit in that sentence. Instead, say something like this: insurance companies, insurers, have fragmented our system so that they can funnel staggering sums of money into their own pockets. See the difference? A real culprit that you can focus on, and be even more specific perhaps than that. Focus on real harm to patients rather than broad concepts. Narrow provider networks, take away our choices and take away our freedoms. Surprise medical bills, bankrupt, innocent patients, delays and denials of care. You might consider a form of rationing, but certainly we have evidence showing that delays and denials are frankly killing people. So rather than relying on heavily, we need to do some, but rather than relying heavily on macro level critiques, instead, I mean, golly gee, you know, we're PNHP, we're, you know, most of us are physicians, are certainly active in actual healthcare delivery. So we have narratives that others don't have. We should use those. We should add those to the national dialogue about the myriad ways that that our narratives expose tangible patient harms. Don't be ashamed, don't be coy about using them. Here's one that I've been bad about: don't impugn the good guys. We do this all the time. I was doing this all the time, and it's hard to break this habit. We unwittingly impugn the government, which is, if you think about it, the very entity we want people to trust. And you're thinking, well, I don't do that. I don't impugn the government. Oh, yes, you do. Oh, yes, you do. Oh, yes, I do. We often put the onus on Medicare unwittingly and make the insurance companies just passively receiving the incompetence of Medicare is kind of how our language implies. So an example, we say this all the time: Medicare is overpaying Medicare Advantage. Who has not said that? Who has not said Medicare overpays Medicare Advantage? That's saying that Medicare is incompetent, inept, you know, and it's not actually what's happening. Instead, corporations are overbilling and defrauding our Medicare program. You can obviously go much further with this than I have, you know, right here, but just as an example, make this hopeful. You know, there's lots of reasons to be hopeful. For example, but one starting point of that is that we don't have to accept the way it is. It doesn't have to be this way. We can change it. And in fact, we are changing it. Golly, look at all the stuff with the AMA and with the students, and there's a million milestones. The bills have more original co-sponsors than ever in the House. We are making progress along all of the key milestones. And in fact, for the first time that I'm aware of, PNHP has been developing a multi-year strategic plan to get us to what we want. That's kind of a new thing. We used to specifically say one leap across the chasm. And frankly, for the decades that we were saying it like that, that was really the right way to say it, because it was clear, simple, effective. You can make all sorts of arguments around it. So one leap across the chasm was really, I think, a very powerful way to frame it. And now, of course, we still would like to take one leap across. We still want to pass the bills, but we're developing a much more robust strategic plan, which you're going to be hearing about over the next few months. And one key component of that is fighting Medicare Advantage. So, you know, we can still need to describe the problem, but we need to sort of not have these long, extended, multifaceted descriptions for most audiences, and instead sort of lay out the vision for what we're doing and where we want to go. So advocates, well, we need to know what the temperature of the room is. And indeed, PNHP has been a leader at that. You know, PNHP, as you all know, has created a lot of the pivotal research that is measuring the temperature in the room. So we need to continue to do that. And of course, we still are. But frankly, at this point, we're ready to start changing the temperature. We're not just about being a thermostat, but good advocacy now requires becoming a thermometer. So know what you're fighting for. You know, we're, of course, keeping the top of line big vision. We're here tonight because we want Medicare for all, and we want to stop the pernicious corporate takeovers by Medicare Advantage and others. Right now, at this phase of the campaign, there are 3 specific things that you're going to hear again later on, and they all involve reaching out to your networks. So the first is the petition. You know, we have lots of signatures on the petition against privatization, and we need lots more. And that's one thing we can all do, is to share this petition more widely. We're also doing a survey, as you know, of Medicare Advantage beneficiaries. We've gotten a lot of responses. We need a lot more. So second action step you can take right now to focus on what can I do is share the patient survey. And then thirdly, of course, we are probably the only organization that can do this third step, which is to get physicians and other healthcare providers who are treating Medicare Advantage patients to fill out the survey. Those narratives from physicians who are treating MA patients, that's gold. And all of our allies elsewhere in the community tell us that if we can get more and more of these, it'd be great. But finally, the next stage of our campaign is going to have more specific and more action and, more specific action steps than that. But we are intentionally not coming up with more specific demands for the campaign right now, because we are collaborating instead closely with National Working Group that Be a Hero is a hero at helping us convene. So we're trying to make sure that when we settle on more specific sort of national demands, that they're the right ones. And that, I think, unless there's some questions for a minute or two, would take us directly over to Dr. Susan Rogers.
Okay, well, I guess there's no questions, so let me get started, but I'm glad to join everyone tonight and to just give a few suggestions on how to talk to not just physicians, but to all health professionals on why we need a single payer program. Now, one of the things is we should never assume that just because someone's in healthcare that they are aware of what the problem is. We see many symptoms of the problem, and especially as doctors, we see those symptoms. But if you don't know what the disease is causing the symptoms, you'll never treat it, because you're not treating the disease, you're just covering the symptoms. So because of that, physicians need to learn about single payer, or how we can address the disease and not just the symptoms. I think many are aware of the symptoms, but they don't really know what they mean. Next slide. So how can you reach physicians? Well, there's a lot of ways, and not just physicians, like I say, but all healthcare workers who interact with patients see the evidence that we have a health system that does not function. One of the things we can do is look to our medical school classmates that we may not have seen in years. If we attend med school reunions, if we go to our medical society groups where we may see some of our classmates, that's a good place to start. And we can bring up the conversation without necessarily having to do a whole talk, but to just find out a little bit about where their thought process is. But this is a good group to reach out to. Our medical societies and our specialty groups, like the American College of Physicians, the pediatric societies, the family practice society, all of these medical societies that many of us go to every year. And one of the things we need to encourage is to do a professional PowerPoint presentation to some of these groups. But this is also an opportunity to just start up conversations, see where our colleagues are, see where their gaps are, and if they really understand the disease that's causing the symptoms that they see. And so this is one of the things we really need to do. And don't forget the doctor's lounge. That's a good place where you can have a casual conversation, you can bring something up, and you can get to the point, make the points you want to make. One of the things I think is really helpful is going through personal and patient stories. And I think when you think about it, a lot of people, when you think about events, when you think about things that really changed your way of thinking about something, and I don't have any data to prove this, but this is what I've just seen in my own life and others, that when emotions are involved, you tend to remember that event and you remember the facts around those events. And that when we share stories with emotions, that's a good starting point. If we look back at how Wendell Potter got associated with PNHP, it was because of the horrific story that happened to a young woman who was insured by the health insurance company he worked for. They refused to pay her liver transplant. And after there was a big uprising, they finally agreed to it, but she died before they could do it. That's a story that you will never forget. Those are the emotions that can make you think differently about the facts that you have ignored. And this is a good way to get people thinking about that, and share your emotions when you get to stories about injustice. And maybe that can help, solidify the synapses that get created in the brain so that people will remember. One of the things that's really a big issue, I think, now is the loss of our professional autonomy. We are, as physicians, we are no longer the ones who make the decisions with our patients about what our course is going to be, what journey is going to go on, what decisions are you going to make in terms of what procedures you want to have, what you don't want to have, how you want to go. And one of the things that is happening is that with insurance companies and other entities getting in the middle of that relationship, it's not the same. And what they have done by decreasing the amount of time that physicians have with patients, and this is done with HMOs, with ACOs, with REACH program, all of these privatized. I know, Ed, you said don't say privatized, but but with these privatized groups that get in the middle of this relationship, what they've actually done is belittled the relationship between a doctor and a patient. They've made it so that that's not important anymore. And oftentimes when decisions are made that patients don't like, they often don't even go to the doctor to help fix it because they don't see them anymore often as how this decision was made, because that wasn't what they agreed on in the exam room. And so it gets to be very difficult. And I think we have to really, in order to be able to fight for single payer, where we and the patient can then make a decision as to what or what not do, we have to get our role back. We have to be autonomous again, and we have to be able to be in charge with patients in helping decide what the course of action will be, not just an outsider who's busy about making money. One of the things we have to make sure that other physicians know that they may not be aware of is just the status quo is not working. It just is not working anymore. And we need to point out the shortcomings that occur with the system that we have now, that we need to improve our traditional Medicare. We need to increase the benefits there. We need to decrease the out-of-pocket expenses, because traditional Medicare, as we all agree, that gives us something that we can build on that will ultimately get us to a system where it is efficient, it is cost saving, and it covers everyone if we have a Medicare for all. So we have to point out too that this is the easier way to go. This is the simplest way to go. And this is the way that we can get everybody covered. And we need to highlight the harm. And I think that many physicians and healthcare workers are aware of the harm that is caused by Medicare Advantage insurers, but they don't necessarily know why. And so it's important that we bring up what this is causing. And it's not just in outcomes that are worse with patients, but how it directly affects us as physicians. We have increase in burnout, which we now call moral injury. And it's when I was training, and I thought burnout was having to be up all night on call, having too many patients scheduled for the clinic. That was what I called burnout. That's what we all called burnout, was too much work. But now it's not being able to be the doctor that we trained to be. It's not being able to have the relationships with the patients that we trained to take care of. And so we would be better off with all of these companies gone, and the burnout, the moral injury would be removed, and we would be able to function as physicians again, the way we used to. So I didn't want to take a whole lot of time, but if there's any questions, if anybody wants to ask, or we can go on to Gaurav and the next speaker.
Mute. I have a question.
Uh-huh.
And it's a personal thing. I'm kind of embarrassed, but I'm a hypocrite. I'm with Kaiser, and I've got their silver plan, advantage plan. I have had $1 million tests, PET scans, CAT scans, because I have some memory issues. And I haven't received one frigging bill from Kaiser or the University of Colorado because they have a contract. They take care of the Kaiser patients well, I think. I don't. So my problem is when I asked them if I could keep the same Kaiser doctors and go on traditional Medicare, they said, no, you'll lose your Kaiser insurance if you don't have this advantage plan, senior, whatever, silver. And so I'd like to tell my story. I have to do more work there to see what it would take for me to be able to switch to a traditional Medicare plan. But I am the problem. I don't have to go to a patient. So anyway, I just think that some of us have take personal advantage of these advantage plans. And it's very hard to give them up if you've known your primary care doctor for 20 years. And all of a sudden, you have to, jump on a different horse. Does that make any sense to you all, or is it too personal?
No, I think that there's a lot within any system, with any structure. I think that there are examples where it works well for some people. And for you, clearly, that insurance has worked well for you. But I think there's many, many stories of where it did not work well for patients, where they were saddled with bills, where they did not get the care that they wanted. So even though it may have worked for you, it may not continue to work later. I don't know. I'm not sure what the plan is specifically that you have.
Well, so I think you have to remember too, one, you're not the problem. So I heard you say that, and it's okay. We all have our own experiences with the healthcare system. And I can say this because I'm a doc who works for Kaiser, right? Am I part of the evil empire while I'm standing up here telling you that we need a single payer Medicare for all program? The truth of the matter is, if we work within our healthcare system, either as patients or as physicians, we are stuck with the system that we have, and so your participation in it is not a tacit approval of it. You may not be able to draw from your own story, but it is okay. You don't have to feel guilt for having a Kaiser Medicare Advantage program. And I appreciate that you would look to try and find a way out of that. But the truth of the matter is many people don't even have that as a choice. The Advantage program is the only one that is affordable for them. And so one of the things we're very careful to do is to not demonize this, right? We want to demonize the companies, but we don't want to demonize the person that depends on this for their care,
I think that's an excellent point, Phil, and I'm glad you made that. And I see some more hands up, but we're going to have to move on. Otherwise, we're not going to get through all the presentations in time. So I'm sorry, but Gaurav Dixon, you going to show a slide?
Yeah. Thank
Okay.
you, Susan.
Those that have
and thank you,
questions,
Dixon.
maybe hold on to them until we get to the end. If we have a little bit more time, we'll try and address some of them.
Yeah, definitely keep them in mind because and if there's any maybe that I can answer in the meantime as well, I can do that in my question section. So yeah, I'm going to be talking to you all about how to reach the general public. The general public famously is easy to have one strategy for, and they all think the same thing. So that should be it'll be pretty quick. But yeah, a couple things to keep in mind, kind of as we discuss this topic in general is to not assume people's backgrounds or situations. And I think the question that was just asked is a really good example of that. People might have Medicare Advantage and really like it. They may not. They may have some other different type of insurance. Our job, as Ed said in the beginning, is to get them engaged with us, get them to sign petitions and fill out the surveys, and put them in a position to learn more about our cause in a way that they'll be receptive to. And so I think, things that you should be keeping in mind throughout all the slides I'm going to be talking about now is, start with those shared values that Ed mentioned, pull people in with messages that are kind of easy to endorse, that get conversations going. If you're tabling, if you're canvassing for the petition, saying things like, what do you think about Medicare being taken over by corporations? Or, would you have a minute to discuss, giving seniors the care they need from any of your doctor or hospital they need it from? Start off with things that are broadly palatable that you think will pull somebody in, and then use that to get more specific and find out what's important to them, and use that to engage with them on the issue of Medicare Advantage. And also plan for questions, thorny questions. I don't have problems with my insurance. What's the big deal? Or, a question like, Medicare has a lot of fraud too, doesn't it? I know doctors get paid for whatever they do, so they're going to do more than they need to do. And so you might know, the data that shows that that's not true, or you might know the data that says, hey, I'm glad that you've had this positive experience, but that's not the experience of everybody. But you need to be able to navigate that. You need to be able to manage it with stories and narratives that really connect with people. So not just throwing statistics in their face, and you want to be acknowledging their concerns and going at things in a productive way. So, saying, I hear you, I understand that that's totally true for you, but here's the reasons I think you should still be concerned. So how to reach the audience in general, right? And as we said, the general public is broad. So there's a lot of different ways to go within this kind of trying to do this outreach. So local seniors groups, other local activity groups in general, really great for in-person conversations and canvassing. They really are often actively looking for people to give presentations or talks. And most importantly, this is one of the places where MA insurers will come in and say, here's an info session about our plan. So for us to do counter programming and those kind of senior collectives is a really good way to make sure that we're not, that we're preventing people from being pulled in. Writing letters to the editor. These are pretty simple to get published, a lot simpler than you might think, especially because, for most of you here, not everybody, but most of you are doctors, and that provides you with kind of an ethos and a clout that a lot of people don't have, that publishers, newspapers know that people want to hear from, that they have a respect for, and especially on healthcare issues, that they'll be likely to publish your stuff for. So don't ever be afraid to submit. More people read these things than you might think. Make sure you keep things short and to the point. Don't get bogged down in too many things, but make sure that you put together the specific details about Medicare Advantage. Mandy's putting in some guides here that'll give you, sources that you can have, and that'll give you a guide to writing letters to the editor in general. Again, make sure you mix those with personal anecdotes. Don't just rely on the data, but that's all there. And if you ever need help on a letter to the editor, you want someone to edit them, you feel free to reach out to me in my email as well. That's one of the things I do for members. So yeah, this will be one of our big action items for things that you can do. So definitely keep it in mind. And then, conversations with patients and, oh, sorry, Dixon, can you go back real quick? Yeah, and conversations with patients and families. So, just general stuff for this, focus on personal connections, things that will resonate, focus on the connections that you have with them specifically. And I'm reiterating those points sort of about making sure you plan for their questions and know ahead of time what they're going to ask. Next slide. So this focus on reclaiming Medicare, right? And this is something that some of our other, partner organizations are doing a lot as well. The problem is not Medicare, as Ed said. Medicare was created as a public health program. It's kind of under attack, right? Or it's being taken over by these insurance corporations. And nobody loves insurance. Some people might be fine with their insurance, but you'll never talk to someone who says like insurance companies are great. Like I love insurance companies. So it's really good to put the impetus on them and to talk about the fact that they are encroaching onto a program that was made for us, right? For the people. So talk about their fraud and their denial, talk about how they can't be trusted, use their names specifically in stories of denial, take examples from your own practice. Those are really good ways that you can focus on saying they're taking it, we need to take it back, and this is what we're trying to do at PNHP. So qualify the term Medicare Advantage. As Ed pointed out, I think maybe we put a little bit more emphasis than we might need to on whether or not the language you use will have a super big impact. If we say Medicare Advantage versus Medicare Disadvantage, will that necessarily make a huge difference? I think what you can do is make sure you append things to it. And we put a couple here, right? Corporate controlled Medicare Advantage, so-called Medicare Advantage, use that to differentiate it from traditional Medicare. Call it the name that it is because you want people to understand what you're saying clearly, but make it also clear with the descriptors that you're using and the stories that you're giving that, hey, this is not this is not the Medicare we want. This is Medicare that they're giving this term to. but that it's something that the industry controls and it's got all the industry problems with it. You know what I mean? So, don't be afraid to use Medicare Advantage, but just make sure you're telling people what it really is as you're using it. One helpful thing to do in writing as well is to just say MA after you say Medicare Advantage for the first time. Just kind of put it in parentheses and then use the just that acronym as instead, because that distinguishes a little bit. It takes out the advantage that some people think, gives a really nice sheen to it. So saying MA in writing as well is helpful. Distinguishing between traditional Medicare and Medicare Advantage, right? As Ed said, don't make the government the villain here, and don't allow the shortcomings of MA to stay in the Medicare program. Make it really clear that these are not the same thing, and that make sure you have the important differences down pat. Like you can point to them immediately. No networks, no approval. None of the money is going to profit. 2% overhead versus 15% overhead, and that's all going to corporations, and made for us, made for the public. Make sure that you have those things in mind whenever you're talking about Medicare and Medicare Advantage to make sure that people really have a clear understanding of what the difference is and why they should be worried about one. And then kind of the final thing here is, and as we reiterate this through everything, connect based on those unique experiences, right? Share those stories that people can relate to. Things from your own life, things from your own practice will resonate really heavily. Especially if they're related to, aspects of care that the person you're talking to is dealing with. Again, all within their comfort zone. But if you know that like a family member of yours, has to take diabetes medication, you can talk about people who've had to do insulin rationing, or if you know that, they've had to go through surgeries or anything like that, or cancer treatments, talk about, hey, do you know all these people that I know? Like it's in the data and I've seen it in my own practice, people with cancer who aren't getting the care they need. They have to leave. They have to, spend a lot of hassle getting back to another regular Medicare program because they're not getting the things that they need, or they're waiting too long for them, You can share experiences that don't always happen to everybody as well, but that people can understand, and that kind of often refers to those real horror stories, like specialty care that was denied, or like a really important rare medication that they just won't cover no matter what. Running through all these procedures so that by the end of the time they get to them, like it's already too late. Like those kinds of things, they may not happen every day to people, that everyone will have a story about it, but they'll understand how it got there because they know that the healthcare system is broken. And make your points to these concrete examples. But here's another key point as well. Don't forget about the power of statistics. They have a lot to say that is useful, and people do respond to them. We just got to make sure we're using both statistics and personal narratives combined, because we don't know what'll work on any one person. So yeah, that's pretty much it, I think, in terms of the general public messaging. I can take maybe one question if we want to call somebody out. Let me see where people's hands are. I think I see a question. Betsy, do you want to go ahead?
All the people I know who chose Medicare Advantage, when they did have a choice, they all did it because it was less expensive. So people
Right.
with low to middle incomes, they really can't afford, original Medicare with a supplement. So that's why they take Medicare Advantage. And I don't know, what can I say to them?
Yeah, this is a really good question, and I'm glad you bring that up. I think, again, being really cognizant of everybody's own, personal issues and the healthcare journey that they have to take. We all understand it's a bad system and we have to do what we can. Being cognizant of that and not attacking anyone for it is the very bottom line. I think the way to draw them in is to say, even if you're on Medicare Advantage, wouldn't it be great if we could all have a system that had no copays, no deductibles, and we could see whoever we wanted and everything would get approved, and say that's what we're aiming for. And because of X, Y, and Z reason, that's what Medicare Advantage is threatening. And say, I'm not trying to tell you to get off Medicare Advantage, but will you support, our drive to make things better for everybody? And I think people can commiserate with that and understand that. And so make it essentially the idea that, hey, we're not asking you to get rid of your Medicare Advantage or telling you you're a bad person for being on it. We're asking you to join with us in order to improve the healthcare system as a whole. And we think that Medicare Advantage as a system is threatening those aims, and this is why. So that's the way that I would go about that. But anyways, that's what I've got to say about the general public, and I think we can turn it over to Dixon.
All right. Thank you, Gaurav. Great points. So we're going to move on to the third audience that we want you to consider here. And hopefully one of the main takeaways that you have from tonight's session is that, before you go into a messaging exercise, before you go into your communication, you really need to consider who it is that you're talking to. We're giving you some broad categories, but certainly any specific person or group that you're talking to will be even more specific than these. So for audience number 3, we're talking about policymakers, academics, and single payer activists. Again, a pretty broad category, but a lot of people who are on the call tonight, and people who have a good deal of health policy expertise. So how do we get in front of these audiences? Well, if you are a single payer activist, a health justice activist, then you almost certainly have an existing activist network, fellow PNHP members, people in your community and your workplace that you work with on single payer activism, healthcare activism, other types of activism. So, reach out to those folks that you already know. Certainly medical societies, if you're talking about academics, are a way to reach people within your specialty society or local medical society. You may have an interest group that's focused on Medicare for All or Medicare Advantage, or there may be the possibility to create one. And certainly medical society journals are a way to reach out and potentially publish something and reach an audience that way. And then if we're talking about lawmakers, elected officials, hosting public forums, they should be hosting public forums. Many do, is one way, and then private one-on-one meetings that you can schedule with your member of Congress or other elected officials. Okay, so what are the points that we want to really stress when we're talking with this audience? One is that Medicare Advantage has an awful record, an established record. Academics and policymakers want to see the data, and the data on Medicare Advantage is crystal clear. We have 20 years of experience showing us all sorts of bad things, from upcoding to delays and denials of care to deceptive advertising and so much more. And the bottom line is that Medicare Advantage firms, commercial insurance companies, insurance corporations, as Ed said, cannot be trusted. They've shown us that over and over again. Also, attempts to regulate these insurers, those are few and far between, but when they do come along, the insurance industry makes sure to get in front of that very quickly and aggressively. There was a recent rule proposed by the Biden administration that would have slowed the growth in Medicare Advantage reimbursement, and that was met with the full force of industry lobbying. And they did manage to at least delay that for themselves. And that's how they're going to meet any kind of even nominally patient-friendly reforms or regulations to their business model. And that makes sense because their business model requires them to be able to skim as much money off the top as possible. In employer-sponsored insurance, they're taking in as much as they can in terms of premium dollars. In Medicare Advantage, they're taking in as much as they can in terms of capitation payments. And then, of course, on the other end, they seek to spend as little as possible on actual care. That's the business model, and that's not going to change. Another point that we want to communicate is that Medicare Advantage is a radical change to the Medicare program. It's called Part C, sounds innocuous, it's just Part C, like Parts A and B and D and G, but no. It really is a significant change to the original vision of Medicare, which was as a social insurance program, a public program, and Medicare Advantage flips all of that on its head. It introduces quote unquote innovations from insurance companies that everybody in employer-sponsored coverage knows very well, like narrow networks and prior authorization requirements and all those sorts of things. Those have no place in Medicare, and the only reason they're in Medicare is because commercial corporate insurance companies have managed to infiltrate the program. And then another point is, and this is just putting it plainly, that the program takes public dollars and redirects them directly into the corporate bottom line. This is indefensible. Policymakers and lawmakers, people who are responsible for the program design, know that they ought to be embarrassed by that fact, and they know that it's indefensible and certainly unpopular when you describe it the way it actually is. That money should be spent on patient care. In the traditional Medicare program, it is spent on patient care. In Medicare Advantage, it goes to a good amount of it goes to shareholders and executives. And also along the lines that Medicare Advantage cannot be trusted, these firms cannot be trusted. The original promise was that the program was going to save a boatload of money because we were going to introduce these allegedly efficient private entities. We were going to let free enterprise have free reign in the Medicare program, and it would be so much more efficient than the allegedly spendthrift federal government. And of course, the opposite has turned out to be true. Medicare Advantage costing much, much more. And the final point, I think, when communicating with this audience is, this is, I think, your opportunity to bring up some of the broader systemic issues with Medicare Advantage. For a lot of audiences, especially the general public, when you're talking about things, privatization or things at a 10,000-foot level, people's eyes can tend to glaze over. But if you're talking to academics, if you're talking to legislators, if you're talking to people who are on board for single payer and really steeped in health policy, then you can talk about things like how Medicare Advantage is a serious drain on the Medicare Trust Fund, how it puts a drain on the federal budget, how it's increasing costs for taxpayers, for doctors, for patients, system-wide. So this is your opportunity to bring up those kinds of issues with an audience that's going to be receptive to it. And especially for Medicare for All activists, this is something that PNHP has said over and over again, but the Medicare Advantage program poses a dire threat to the Medicare for All movement. We're talking about Medicare as kind of, a basis, a current basis as a public program for what we envision a single payer national health program might look like. It's something we can build on. And as Medicare Advantage takes over more and more of the Medicare program, then Medicare becomes a less and less desirable foundation for the single payer program that we know we need. So with that, again, the main points to take into account: Medicare Advantage has an awful record. It's a radical change to the Medicare program. It's redirecting public dollars directly into private hands, and the whole Medicare Advantage system is rotten. So I think we have time for maybe one quick question before we go over to our friends from Be a Hero. So I see that Nancy, you've had your hand raised for a while. So do you have a question?
Thank you. Two quickies. One is, as I approached the age of Medicare, I had many friends doing sales job on their MA programs. And my point is, MA programs are great until they're not. And when they're not, they're bad. Second of all, I've been involved in PNHP to various degrees for a decade or so. And I think an elephant in the room is that it's under our roofs. You don't have surgeons, proceduralists, radiologists come to PNHP meetings, and selling them, I find next to impossible. And I don't know how we're ever going to get anywhere until we have these colleagues join us.
I guess I would say to that, fortunately, they still represent the vast minority of physicians in America. But your point is well taken, and I say that as an ICU physician. It can be hard to get our subspecialty colleagues on board. We certainly have a few that are dyed-in-the-wool single-payer supporters, but certainly something for us to focus on. And I'm not sure that a subspecialist necessarily is tied into Medicare Advantage one way or the other, but from a more broader strategy, I think that's a fair point. We should probably move on to Carmen. Carmen from Be a Hero. We'd love to hear
sharing my slides now, but yeah, this is a picture from the recent action, and Carmen has some things to share with us. So I will take care.
All right. Well, hello, everybody. I am so happy to be here with you all tonight. We love working with you all at PNHP, and we are some of your siblings in the fight to win Medicare for all. We're an organization that fights for healthcare justice for all. We were founded by Adi Barkan, who's an ALS activist who's really used his own story navigating the healthcare system to lift up what's broken about it. And he says all the time, in the wealthiest country in the history of the world, we all deserve healthcare. No ifs, ands, or buts about it. So we're your siblings in the struggle. We also share the analysis that if we want to get to Medicare for all, we have to improve actual Medicare, traditional Medicare, and we have to fight back against the corporate takeover of Medicare that's happening. So my job is to tell you a little bit about how we took all this information, all this communication, this wonderful communications information that you've received tonight, and put it to practice. So Medicare just turned 58 years old on July 30th. And we really saw that moment in time was a moment where we wanted to start to lift up the need to reclaim Medicare from corporate greed and from these greedy corporations. So we had a birthday party and set of actions for Medicare in Washington, D.C. on July 25th, and then a distributed day of action on July 30th. And we had folks from your New York chapter join us in DC. I saw Nancy Greep was on the phone, and she hosted a birthday party with us in Santa Barbara on July 30th. And so we love working with you all, and we were partners in this action. So I just wanted to show you a few things of what we did. I'm going to share my screen. I hope everybody can see the screen. I want to close this chat. Okay. So here we are. So we had lobby visits with members of Congress. We also had a speak out in the atrium of the Senate building, and we had a press conference with members of Congress and a couple of storytellers who shared their horrific experiences trying to navigate Medicare disadvantage plans. So this was the leave behind that we created for Congress. And you can see, health insurance corporations are taking advantage of Medicare taxpayers, older adults, and disabled people. So very clear statement. I'm not saying that we did all this perfectly. We've had a lot of the same debates that I think you all are having internally about how to talk about this, but this was our bite at the apple. This was how we did it, and we can go from there. So we defined the problem. Health insurance corporations are denying care they are supposed to cover in Medicare Advantage and putting older adults and people with disabilities in harm's way. Health insurance corporations are gouging the federal government and taxpayers, and health insurance corporations are not being held accountable for their bad acts in Medicare Advantage. So then the solution followed the problem. So ensure what Congress can do about it. Ensure older adults and people with disabilities can access the care they need. We're talking about strengthening traditional Medicare there. So it's a values-based statement that gets us to that. Stop corporate health insurers from scamming the government and profiteering at patients' expense, and hold the bad actors accountable. So those were the way that we framed the three problems. This is what we said Congress can do about it. I just want to show you a couple other things, just because I think these things are so beautiful. Oops, that's the back. So this was the leave behind that we had in the Hart Atrium. So happy birthday, Medicare. Medicare is turning 8. It's time to strengthen Medicare and make it work for patients instead of greedy corporations. And then on the back, it said, it's Medicare's birthday, but health insurance corporations are stealing the cake. And then you can see that we have our 3 bullet points. We need to strengthen and improve Medicare, stop the wrongful delays and denials of care for people on the privatized plans, and kick Medicare disadvantage bad actors out. So we really used these 3 themes: strengthen Medicare, stop the wrongful delays and denials, and kick the Medicare disadvantage bad actors out. That was really our rallying cry for the press conference. That was how we sent the talking points out to all the members of Congress who spoke. And I just want to quickly show you the result. So here's the article that came out in Common Dreams. We had a number of national news stories. Here you see Senator Warren speaking at the press conference, and you can see our signs. So this is how we turn this into very quick slogans. stop the deadly delays and denials. Medicare Advantage makes us sick. Over here, it says Medicare, not Medicare, not Medicorp. And then you can see the headline, which I think is right in line with what we want to be saying. So we're raising the alarm about the Medicare Advantage scam. It's time to call out so-called Medicare Advantage for what it is. It's private insurance that profits by denying coverage and using the name of Medicare to trick our seniors. So a lot of the press that we got was right in line. I'm out of time now. I think my timer is going off. But I also just, if you have a chance to go to Be a Hero's Twitter feed or to Audie Barkins, you can see from July 30th how we put this into the social media day of action. I think I've got Nancy Greep's birthday party right here somewhere, but you can see from that day of action how we took all of this. Here's Nancy Greep's birthday party in Santa Barbara, how we took all of this and put it into a real comms strategy that I think starts to really nail who the real villain is and why this is such a huge problem and what we need to do to stop it. So with that, I'm going to stop because I think my time is up. I'm going to stop the share and pass it to the next speaker.
Fantastic. I'll take it back over. Thank you, Carmen, so much. And I think it's important to see that the themes that Be a Hero is pushing are the same ones we're talking about. We are all working together towards the same common goal. And the more that we can share these same kinds of messages consistently, the more those messages have power. And so as we wind this thing down, I want to just reiterate a few things. There are things that you all can do. So one is writing a letter to the editor. We want to see letters in, if you're in Chicago, you don't have to write to the Trib, try and find the smaller town newspapers. We get those things published. Sign and share our petition. So we've got a petition basically to say, we want the elimination of Medicare Advantage, the oversight. We want to take the, take the power away from those privatized insurance companies. We've got the surveys, both for physicians. What is your experience with Medicare Advantage? And for patients, what's been your experience with Medicare Advantage? We are collecting that data to use in this fight. We've got a kitchen table campaign website. You've seen the link in the chat there, but if you go to our PNHP.org website, we've got all of the tools, all of the evidence, all of the things you need to craft your argument for how you want to have the discussion with whoever your audience is. We've got the protectmedicare.net website. These are all places that have all of these same consistent messages to help you in creating this fight. So I think with that, it is the top of the hour, and I know we are want to be mindful of people's time, but certainly thank you all so much for attending. And if you have questions, feel free to reach out to us and comments. I think getting this messaging right is the next big thing that we need to tackle in our advocacy, both against Medicare Advantage, but ultimately in our fight for a single payer Medicare for all system in this country.